Good morning, friends. Myself, Dr. Vipul Gurjar. I am the practicing surgeon and special interest in anorectal surgery in Vadodara, as well as I am a professor and head of the surgery in Vadodara Medical College, SBKS Medical College, Vadodara. Today, I'm going to discuss our sweet and old technique about the Milligan Morgan technique. After the coming of many newer technology like a laser, MIP, star procedures, DGHI, FHA, FGHL, everything, the people are considering that our hemorrhoidectomy is gone. There is no future of this Milligan Morgan hemorrhoidectomy. It has a lots of complication. No, at present now also in compared to all other our newer technique, the Mulligan Morgan is a promising surgery. So don't worry about the its unavailability or unsuccessful treatment. Don't consider this in all the book of general surgery. There is nothing mentioning that Milligan Morgan is now out of date and it is a contraindication. Now, I am giving you one some clues that if you are expert in the MIPH, or if you are doing the laser surgery, or you are doing something else, and you got the complication or some the recurrence of the surgery, or some there is a residual non-effectiveness of your new technique. Once this patient is coming to back to you, what will you do for this patient? And what is in your mind to do in this case? Definitely one further only surgery come in our mind is a Milligan Morgan. That why? Because we are so much confidence about its result. After my MIPH recurrence, after my laser recurrence or anything else, I am doing the only the hemorrhoidectomy. Though we can redo this our newer technique to implement further to get the result, but the confidence of hemorrhoidectomy result is nothing like a comparable. Now, second thing, I am giving another example. If patient is coming like a large thrombus infected pile mass, or the large external pile mass with some infection, you may have a stapler, you may have a laser also. This patient is coming at 7 o'clock, 7 evening, and the patient required, sir, I want to go for the surgery as early as possible because of this unbearable pain. And this type of surgery, if you are doing at the some late early night of day, what is the choice of your surgery? Is the stapler, is it a laser, or the simple hemorrhoidectomy? I'll do the hemorrhoidectomy because I want to sleep very well in the night without any fear of adverse outcome of hemorrhoidectomy. So hemorrhoidectomy, it's still gold standard and promising surgery. But what are the problems of technical problems and the outcome of hemorrhoidectomy? See, I said you in many lectures that the piles is a symptoms of disease of constipation. It is not a primary disease. So, when the patient having a circumferential mucosal prolapsing piles, or second thing, the patient having a rectal intussusception, then the after the hemorrhoidectomy, patient will get the benefit of removal of hemorrhoids, but they are not satisfied about their another complaint of constipation. So we are doing the cosmetic surgery in a case of piles with the intussusception or the mucosal prolapse. So that's why newer technique, star procedure, MIPH have some benefits over there. As well as the patient, we are thinking about the severe post-operative pain of this Milligan Morgan in compared to MIPH or the laser surgery. But no, it is not that much painful if we follow a step. As well as we are worried about the bleeding, peroperative bleeding in a hemeroidectomy in compared to laser or the stapler. No, if we are doing in a good manner and if we are following some basic step, then we can get a bloodless field. So how to do this hemeroidectomy? In my technique, I am giving some explanation. First, I am not doing the hemeroidectomy in a second degree piles, or I am not doing the hemeroidectomy in a circumferential piles. My preferred the indication of Milligan Morgan hemeroidectomy is isolated large external component over the internal component. I will go with the hemeroidectomy. But if patient having a large internal piles with the mucosal intussusception, I will prefer my another surgical method. How I do after the under anesthesia? My first step is the xylocaine adrenaline infiltration or adrenaline with the sensor can infiltration over the perianal region that gives some bloodless field. Then if patient is associated with the fissure, then and then I do the sphincterotomy. Otherwise, in a routine, I'll not prefer the sphincterotomy for a hemorrhoidectomy because the indication of piles is mostly a third degree prolapsing piles, and once the patient having a prolapsing piles, the sphincter is always be a lax. So there no need of routine sphincterotomy for a hemorrhoidectomy. Then I use a half anoscope, that is what we are using a MIPH for the better visualization. I'll catch anoderm or mucocutaneous junction with the Alice forceps for the good visualization. Then I'll take 2 to 3 centimeter above the pile pedicles. I am taking a single interrupted or figure of 8 suture to make a less vascular, that means to ligate the feeder of piles. This may reduce the bleeding during the piles dissection. So 2 to 3 centimeter above the piles pedicles, not the dentate line. I am giving you the 2 to 3 centimeter above the piles pedicle. Then keep this thread somewhat long if we require to do anything else. Then with the cutting mode, I am starting the cutting or the mucocutaneous junction slightly above the mucocutaneous. I am trying to preserve the skin as perianal skin or near anal verge as much as possible. And I use the cutting mode. Then the small spark of coagulation mode to elevate the pile cushion from the sphincter fiber. You should not cut a sphincter fiber anyhow. Now, in routine practice, I am using a two method of this, surgical dissection. One is the using a simple hand cautery, as well as I have made 8-inch long bipolar cutter what we are using in a laparoscopy. So this is also a very good instrument for a pile surgery. It acts like a poor man harmonic. So, and the person who is making this laparoscopy instrument, they may they make you the available such a customized bipolar handpiece. Routinely I am using artery forceps and one Ellis forceps at the lateral side, while one artery forceps over the medial side. With a good traction, you continue dissection your pile mass from the sphincter fiber. Once you give the small stroke of cautery, like a there will be a separation like a pneumoperitoneum, and all the vascular structure may lift up from the sphincter fiber. And please try to remain converged towards the pile mass only, and try to keep mucosa as much less cutting. Continue this dissection up to the pedicles. Then I am transfixed with the vehicle 20, and I'll keep this thread needle end along. I'll keep non-needle end a smaller, like a 1 inch to 1.5 inch. Then I'll observe any for the hemostasis. If everything is okay, now I continue using this pedicle, which is transfixed with my vehicle 20. I use same needle and the perianal margin from where the piles dissection is started. I'll take this perianal suture and the tie. So the remnant piles pedicle cover the tissue of a raw area, so it will definitely decrease the pain. And after taking these pedicles, I took another one suture lateral side and one suture on medial side of these pile pedicles in the same manner with the interrupted manners. So the whole dissected raw area will be covered with the pile pedicle, remnant pile pedicle. So this will decrease the pain as well as oozing on the patient, as well as it gives a good healing property as well as good cosmetic result also. Now the post-operative, I'll put diclofenac suppository, as well as I am also using a betadine suppository of a gynecological person to prevent any secondary infection. And if you are too much worried about the pain, then I am infiltrating the methylene blue 2 cc with the 4 cc sensor cane surrounding the perianal region, with the explanation of that bluish discolored urine in next for 24 hours, which may last for the 3 to 4 days. Another, if you are still worried about the post-operative pain, then you can apply the transdermal any analgesic patch, which will benefit to the patient. Normally, post-operative with the xylocaine and cream-based application over the perianal wound and seeds bars is sufficient to give the very good pain control in hemeroidectomy. So this is a Miligan hemeroidectomy, but it is somewhat modified to the Ferguson hemeroidectomy to cover the raw area, and it is very easy. And this is a promising result for removal of pile mass. So don't worry about any outdated condition of leading thought about the Milligan Morgan that it is outdated. No, it is still alive and it gives a promising result. In my YouTube, I have given one hemeroidectomy surgical method also. So go through it. If any query, please let me message. I will try to clear your queries. Thank you. Thank you very much. Bye.